Right. So that's the key question, because we had 25 patients out of 70 go on to active surveillance, per protocol active surveillance, meaning there are some patients who chose active surveillance when really they weren't sort of supposed to based on the protocol, but 25 really had a mutation, had no evidence of disease, and went on to surveillance. And out of those 25, as you said, over 60% end up having a recurrence. Now, mind you, many of those patients were able to be treated with intravesical therapy and still have their bladder intact, are metastasis free, and are alive. But 68% recurrence rate, even if it's not muscle invasive, is high, and that's not what you're shooting for. So one of the things that we came away with is if you have a recurrence on active surveillance, we believe you have to be very aggressive in treating that recurrence, probably with a cystectomy, if at all possible. So sort of monitoring those patients or doing more intravesical therapy for those patients is probably not the right approach because they seem to have chemotherapy-resistant disease, secondary occurrences of disease, and the patients really need to be treated aggressively. Otherwise, you're basically taking a risk of having metastatic disease. That's sort of one big takeaway. The second one is that this isn't for everyone, and you have to, if you do this approach, you have to go into it with patients knowing that there is a significant risk of recurrence. And number three, the chemotherapy we use MVAC, accelerated MVAC, is probably not the best systemic therapy that we should be using. So combining it with immunotherapy probably makes sense. And that trial, RETAIN-2, we ran and is actually completed and will be reported the initial results at GU ASCO 2025. But also probably doing some adjuvant therapy is key. And of course, now drugs like enfortumab vedotin and pembrolizumab are being combined and trials are being opened using that systemic therapy. So in other words, improving systemic therapy is going to be key because doing it the way we did it is simply not good enough, I would say, for everyday clinical practice. The recurrence rate is just too high. Right. So our primary endpoint was 2-year metastases-free survival. And we chose that endpoint because, on the one hand, metastases-free survival is a hard endpoint that everybody can agree is clinically meaningful. It is an endpoint that we can assess relatively quickly. We did mandate that all patients get to that point, so the assessment was robust from that standpoint. What we saw is that the 2-year metastasis-free survival that we got, although it fell short of what we would call the study being positive, it actually fell short by only one patient, and our benchmark was pretty high. And number two is it was actually very consistent with many prospective phase 2, phase 3 clinical trials in this space. So if you look at other trials with muscle-invasive bladder cancer patients who all got neoadjuvant therapy and then went on to a cystectomy, their 2-year metastases-free survival and their overall survival was completely consistent with what we got. So if you think about it then, we got the same results for the group in its entirety, and yet we had a significant number of patients be spared a cystectomy. So to us, that sort of proves the feasibility of this approach, that in fact you can achieve the same potentially long-term outcomes, metastasis-free survival, overall survival, and yet find a subgroup of patients who can be spared a cystectomy. Now, that is not to say the trial was positive, and again, that's not to say that this is ready for prime time, but what it is to say is that we need to tweak it, we need to build on it, and that this is an approach that is doable, and it's an approach that's of high interest to patients because it improves quality of life. You get to keep your bladder. So I sort of briefly mentioned that before, but let me expound a little bit. We need improvement in this process to move this forward clinically. That improvement probably will include things like Adding immunotherapy to chemotherapy. That's already happened and are happening. Doing it in the neoadjuvant setting and the adjuvant setting. Number two, probably integrating ctDNA and potentially urinary DNA in the analysis. So you, for example, would not want to put somebody potentially on active surveillance who is still shedding tumor DNA in say, their urine. Or you would think twice about putting somebody on active surveillance who has positive ctDNA. Okay, so that needs to be, I think, integrated. Better imaging with, for example, MRIs may be helpful. I'm not 100% sure that'll be the case, but it may be helpful. The way we do our biopsies have to be very protocolized and mapped out and not random, which we try to do, but needs probably improvement as well. And so future trials need to really consider all of that when deciding who the right patient really is for this approach. I think furthermore, probably you need larger phase 2 trials to really solidify this method. A randomized trial would be wonderful, but I think it's very difficult to do a true randomized trial from the start. You may be able to do a randomization once somebody receives neoadjuvant therapy and is clinically in a complete response, and there's equipoise to randomize to either, for example, surgery or active surveillance. So there definitely needs to be more work done, but I think this was one of the first trials to use this approach, and it kind of lays the foundation for this methodology moving forward.